Hello everyone. Today we are going to see the topic tooth mobility. Tooth mobility, as you know, is one of the common signs of moderate to advanced periodontal disease. And as far as periodontal diseases are concerned, patients usually seek treatment when they come across mobility, primarily because of fear of tooth loss. And it is the primary factor that is considered while assigning the prognosis of a tooth. Coming to the definition of tooth mobility, Kerr in 1996 has defined mobility as a visually perceptible movement of the tooth away from its normal position when a light force is applied. So what you have to note in this definition, first thing is it is a visually perceptible movement that is we should be able to see the movement of the tooth. And the second key point is when a light force is applied. Now, tooth mobility can be primarily classified into physiologic or pathologic tooth mobility. Now, physiologic tooth mobility is the limited tooth movement that is allowed by the resilience of an intact and healthy periodontium upon application of a moderate force to a tooth. The physiologic tooth mobility occurs in two stages. You have an initial or the intrasocket stage and the secondary stage. Now, this intrasocket stage of mobility occurs rapidly. That is, upon application of a force, the tooth moves within the confines of the periodontal ligament space. That is, whatever is the width of the periodontal ligament space, that much movement occurs during the intrasocket stage. And this is associated with viscoelastic distortion of the periodontal ligament. Now, the forces that are required to bring about this intrasocket stage of tooth mobility is about 100 pounds, and the range of movement of teeth in the intrasocket stage of mobility is about 50 to 100 microns. Now, the secondary stage follows the intrasocket stage, and this occurs gradually or more slowly, and it involves elastic deformation of the alveolar bone. And it occurs with forces of about 50 pounds with a range of movement that is different for different teeth. As you can see, it's the maximum for incisors of single-rooted teeth, that is about 100 to 200 microns. Less in canines, that is 50 to 90 microns. The least for premolars, 8 to 10 microns, and slightly more for the molars, that is 40 to 80 microns. Now, when the applied force is withdrawn, the tooth returns to its original position in two stages. Again, just like the intrasocket stage, there is an immediate spring-like elastic recoil, and second is a slow asymptomatic recovery movement. Now, this physiologic tooth mobility can be influenced by various factors. It has got a diurnal nocturnal variation that it is greatest in the morning. Now, this is attributed to the slight extrusion of teeth during sleep because of lack of contact. Now, as you all know, we cannot sleep with our teeth in occlusion. Okay, and afterwards, during the waking hours, this physiologic tooth mobility gradually decreases. It is more in single-rooted teeth, as we have seen, more in tooth with short conical roots. Okay, the root length is again a determinant. More in children due to incomplete root formation. During the eruption period and all, you will see that the tooth is mobile. And in females, it can be influenced by the hormonal changes. Okay, so the hormonal influences on periodontal blood flow can affect the physiologic tooth mobility, and that is because of this, the physiologic tooth mobility is accentuated or increased during pregnancy. Now we come to pathologic tooth mobility. Now, any mobility beyond physiologic range is considered as pathologic tooth mobility. Now, the principal causes of pathologic tooth mobility are three. One, the loss of supporting alveolar bone, or in short, bone loss. Second is trauma from occlusion. And third is extension of inflammation to the periodontal ligament from gingiva or the periapical area. Now, for whatever reasons tooth mobility occurs, we can categorize those reasons into any one of these three basic causes. Okay, so bone loss, TFO, and inflammation. Now, you can have other causes. Again, please note that these other causes come under the three basic causes that we have already seen, like pathologic processes of the jaws, like cysts and tumors, which can actually lead to bone loss. It can be seen during pregnancy and prolonged use of hormonal contraceptives when it is associated with inflammation. There, it is the inflammation of the periodontal ligament that contributes to this mobility. Dentoalveolar trauma, again, here it is the traumatic forces that causes tooth mobility. Excessive force during orthodontic treatment, again, traumatic forces. Now, you will see a transient or a temporary increase in tooth mobility following periodontal surgery. Now, this occurs due to the severing of alveolar crust as well as the transeptal group of fibers. Because when you are doing a flap surgery, we are severing or we are incising the transeptal and the alveolar crust group of fibers, which are essential for maintaining the teeth in their position. So when we cut those fibers, the tooth will have more freedom to move, and that is why following periodontal surgery we will see a transient increase in tooth mobility. Now, mobility cannot be attributed to any specific microorganism, yet studies have shown that the pockets in relation to mobile teeth can harbor higher proportions of organisms like Campylobacter rectus, Streptococcus micros, and Porphyromonas gingivalis. Now, Porphyromonas gingivalis, as you all know, is the most important periodontal pathogen. So, whenever you have a pocket or whenever you have a mobile tooth associated with a periodontal pocket, and if you take a microbiological culture of the pocket contents, you are more likely to find these organisms. Now, how do we examine tooth mobility? The most commonly used method is manual method. That is, the tooth is held firmly between handles of two metallic instruments and it is tried to move in all directions. That is, labiolingually and mesiodistally as well as occlusally. Okay. And instead of two instruments, you can use one finger and one instrument, but never use two fingers for assessing tooth mobility or evaluating tooth mobility, because the pads of the fingers are soft tissue, so it can get compressed, giving you a wrong feeling of or wrong perception of tooth mobility. Now, in the posterior teeth, especially the mandibular posteriors, it may be sometimes difficult to place two instruments. So, instead of using the handles of two instruments, you can try to engage a pit, a prominent pit in the occlusal surface, can be engaged by an explorer and try to move the tooth. And the movement is always observed relative to the adjacent teeth. And this is how we check the mobility with one instrument and one finger. As you can see, the pad of the finger is soft tissue, it can get slightly compressed, but ideally mobility has to be assessed by holding the tooth between two hard surfaces, that is the handles of two instruments. Now, how to grade mobility? You must have heard mobility being described as grade 1, grade 2, grade 3. Now, basically you have two commonly used methods of grading mobility. One is given by Carenza in your textbook. That is, you have normal mobility, then grade 1, grade 2, and grade 3. Now, grade 1 mobility means the mobility is slightly more than normal, grade 2 moderately more than normal, and grade 3 is severe mobility, facial-lingually and mesiodistally combined with vertical displacement. Vertical displacement, or the tooth can be depressed in the socket or compressed in the socket. Now, this is more of a subjective sort of grading. So you have a more objective method of grading tooth mobility, that is known as the modified Miller's index. Here it is given score 0 to 3. Score 0 means there is no detectable movement of the tooth upon application of force. Score 1, mobility is greater than normal. Score 2, mobility of up to 1 millimeter in a buccolingual direction. 1 millimeter means relative to the adjacent teeth. The tooth in question can move up to 1 millimeter more than the adjacent teeth. And score 3, or severe mobility, or what we call as grade 3 mobility, is movement of more than 1 millimeter in a buccolingual direction combined with ability to depress the tooth in the socket. And you have, instead of the manual method, you can go for electronic evaluation of tooth mobility. Now, periodontometers or mobilometers are certain generic names which have been used in the past to denote this equipment for measurement of tooth mobility. Now, you have many commercially available equipments for measuring tooth mobility, out of which the most popular one is what is called as perio test. Now, it is a commercially available device. As you can see, the latest version is it's a handheld device, and it will, show the here. One thing what you have to know or note is it is not graded like grade 1, grade 2, grade 3. You have values, perio test values of mobility of a tooth. Okay, so it will be digital readouts will be given certain values denoting the range of mobility, and you can check the mobility of natural tooth with perio test, but most commonly this device is used for checking the mobility of dental implants, because compared to the tooth, mobility of an implant means it's a sign of a failure. Okay, implant going for a failure. So to detect any initial occurrence of mobility in implants is very critical in the survival of the implant. So the example of an electronic evaluation device of tooth mobility is perio test. And you would have probably come across another term known as Fremitus. Okay, these are related terms, mobility and Fremitus. Fremitus usually we check for assessing trauma from occlusion. Now, Fremitus is also known as functional mobility. Okay. Now, in Fremitus, what do? Is we measure the vibratory patterns of the teeth when the teeth are placed in contacting positions and movements. That is in mobility, what do? When we check for mobility, we elicit the movement of the tooth using our force. Okay, we are using our finger or the handles of two instruments to elicit mobility of the tooth. Here, the occlusal force of the opposing teeth are used or utilized for checking the tendency of the tooth to move or to get displaced. So, measurement of the vibratory patterns of the teeth when the teeth are placed in contacting positions and movements. And you all know about, I'm not going into the details of Fremitus further. You place a index finger or thumb at the cervical area of the tooth. Okay, and you will ask the patient to bite in various positions like centric occlusion, edge to edge bite, lateral movements, protrusive movement, etc. So the main difference between Fremitus and mobility is that Fremitus is tooth displacement created by the patient's own occlusal force, whereas mobility is elicited by the operator. Now, in this context, you have to be aware of this condition, that is tooth hypomobility or reduced tooth mobility. Okay, a tooth can present with even the physiologic tooth mobility can be absent in a tooth. This occurs in cases of ankylosis, that is where there is lack of periodontal ligament and the tooth is directly attached to the bone. So in ankylosed teeth, the tooth mobility will be even less than the normal physiologic tooth mobility. Now, coming to the management of tooth mobility. Now, just like any condition, the most important thing in the management of tooth mobility is determining the cause. Okay, so we mentioned about the basic causes, that is bone loss, trauma from occlusion, and inflammation. So you have to look for the cause which is contributing to the mobility of the particular tooth in question, whether it is due to bone loss, whether it is due to trauma from occlusion, or whether it is due to inflammation. See, inflammation contributing to mobility is very evident in the case of abscesses. In abscess teeth, many times we find that after abscess drainage has been done and when you review the patient, the mobility would have subsided. So it means that it is the inflammation that has contributed to the mobility in such cases. Okay. Similarly, trauma from occlusion, you have various tests for trauma from occlusion, clinical as well as radiographic diagnostic techniques are there. So depending on that, you will find whether trauma from occlusion is present and that is contributing to the mobility. And alveolar bone loss, obviously, you look for pockets and attachment loss and radiographic bone loss to see whether the bone loss is contributing to the mobility. And the second important thing is determine whether the mobility is stable or progressing. What is understood by stable mobility or progressive mobility is that stable mobility means mobility has already occurred, but then that mobility is not increasing beyond that point. Today you are seeing the patient, next year you are seeing the patient, you are seeing after 2 years, 3 years, 5 years, again the same grade of mobility will be there for the tooth. So it means that mobility has occurred, but it is stable, it is remaining stable. Now, the second condition is progressive mobility. Progressive mobility means the mobility is increasing. Today, you are saying the mobility, checking the mobility. Now, next week, next month, you are checking, it means the mobility has increased. So, it means it is a progressive mobility. Now, if the mobility is stable, evaluate over a period of time by frequent recalls. And if the patient is concerned about mobility, manage according to the cause. Now, mobility due to trauma from occlusion and inflammation are completely reversible. Okay, so you can relieve the tooth of trauma and you can treat inflammation by your instrumentation, that is mean periodontal debridement or scaling and root cleaning. Now, trauma from occlusion is corrected by occlusal adjustment, and inflammatory conditions, as I told, is treated by your periodontal instrumentation. This will reduce the mobility if the causes are TFO and inflammation. Now, mobility resulting from loss of alveolar bone may or may not be reversible, depending on the possibility of bone regeneration following treatment. That is, you have learned about the types of bone loss, patterns of bone loss. So, if it is horizontal bone loss, there is limited chance or limited scope for improving the bone levels. Whereas in the case of vertical bone loss, you may be able to improve the bone levels by means of regenerative methods. And in cases of severe mobility causing patient discomfort and the patient is not willing for extraction, then you can resort to splinting. Okay, and hopeless teeth should be extracted. Okay, so you have to assess the mobility, see whether this mobility can be managed somehow. If there is no, no way possible to retain that tooth, or the tooth is at the verge of falling down, then there is no point in giving false hope to the patient and trying to save the tooth. So it is better to extract it. Otherwise, you can try to retain the tooth, like based on what is the cause and what are treatment modalities you can do. So this concludes our topic on tooth mobility. Thank you.